Hello, I'm Dr. Josephine Yusun Sunga, and I'm head of the Nestle Nutrition Institute. Welcome to the NNI 96 workshop with the theme of Strategies in Neonatal Care to Promote Optimized Growth and Development, focus on low birth weight infants. According to the World Health Organization, an estimated 15 million babies are born too early every year, and that is more than 1 in 10 babies. Despite intensive nutritional strategies for premature infants, the challenge is preventing growth failure and achieving short and long-term health outcomes. For this workshop, we will bring you the latest scientific knowledge on the optimal care of the premature and low birth weight infants and the strategies to optimize feeding, nutrition, and growth, and the updates on the role of HMOs, human milk fortification, donor banking, and many more. We are very honored to have with us the chairpersons for this workshop. So session 1 is on optimizing nutrition and growth in the NICU and after discharge, and this will be chaired by Professor Nick Embleton. Session 2 with a topic on personalized nutrition of the preterm infants will be chaired by Professor Ferdinand Hashke. And for session 3, on the role of HMOs and the microbiome in the health of the very low birth weight, is chaired by Professor Lars Boe. So just a few guidelines for this workshop. All the presentations are recorded. A live Q&A will commence after the lectures for the session. You may type in your questions on the Q&A box on the page, and a link will be sent to you after the event so you may revisit, and please do share with your colleagues. So let's start with session 1 on optimizing nutrition and growth in the NICU and after discharge. So I'd like to introduce Professor Nick Embleton, a professor of neonatal medicine, Newcastle University, and is a consultant in neonatal pediatrics. He is associate editor of the Pediatric Research, and his current interests are preterm infant microbiome and the metabolome, necrotizing enterocolitis, breast milk feeding, breast milk fortification, and donor milk. Welcome, Professor Nick Embleton.
So my name is Professor Nick Embleton, and I'm going to be chairing this session today. I'm delighted to have been invited by the Nestle Nutrition Institute and delighted to be supported in the workshop today by so many experts in the area of neonatal nutrition. And in this session, we're going to be covering aspects of how to start and increase milk feeds in babies, clearly a very important issue for many babies on the neonatal unit. We're going to cover aspects of definitions around SGA and IUGR. We're going to have some talks looking at nutrition interventions and the impact on brain outcomes. We're going to move in, think about the post-discharge area, thinking particularly about the continued importance of breastfeeding and the complexity of introducing complementary foods into preterm babies. And then we're going to finish up thinking about some of the complex metabolic aspects and the relevance of the quality of growth in babies and the impact of body composition in early life on later metabolic outcomes. So I really hope all of you have a lot to learn and enjoy the speakers in this session. Thank you. So my first speaker today is Dr. Janet Barrington, who's a colleague of mine here in Newcastle. Dr. Barrington trained in the UK and Australia and completed her MD in neonatal immunology. She established the Great North Neonatal Biobank that's led to numerous high-impact papers already, and has also been a key member of large randomized controlled trials conducted in the UK, and particularly SIFT and ELFIN and MAGPIE. She's a translational researcher, taking research from the lab back to the NICU with a big focus on the microbiome and the metabolome, and has published a number of studies that include looking more recently at things like human milk oligosaccharides. And she's particularly interested in making use of what are called salvage samples, but also in the development of gut-enteroid systems that you'll hear about in other sessions today. And Dr. Barrington is going to be talking on starting and increasing feeds, milk tolerance, and monitoring of gut health in preterm babies. So thank you very much.
So thank you very much for the invitation to speak. Just by way of context, I'm a neonatal clinician and I work in this beautiful city, which is Newcastle upon Tyne, which is in the north of England. And it's a big, busy and socially deprived setting where our breastfeeding rates are naturally low. So the audience will be familiar with this complex environment of the neonatal intensive care unit, but it's one where we're asked to make many practical decisions around feeding very early babies on a daily basis. So as well as that, I'm research active. I was one of the key members of the SIFT study that we'll discuss, but I also undertake mechanistic trials and I manage the Great North Neonatal Biobank. So what we're really talking about here is how we take a baby from a position where it's been intravenously fed in utero to hopefully a happy, healthy breastfeeding baby. And if you're a term baby, that journey is hopefully moderately straightforward and direct. But for our most tiny babies, that journey can be very complex. And it's complicated not just by the baby's physiology, but by the choices that we make every day around milk practices and feeding practices. And many of those practices are dominated by our desire to not ever have a baby develop this devastating condition of necrotizing enterocolitis. And whilst NEC is a very important outcome, it's not the only outcome that relates to how we introduce and continue to feed our very early babies. So I'm just going to spend a minute or two thinking about the outcomes that do matter and then what we should be aiming for as measures of success when we enterally feed. And as we do that, we need to remember that feeding babies is a complex intervention and that the relevant outcomes are multiple and potentially competing. We also need to remember that when we feed a preterm baby, we also feed bacteria. And there is this complex interaction between the bacteria that the baby is establishing in its gut and its health. So when the baby is allowed to host bacteria, those bacteria modulate the host response. And that modulated host response educates the immune system and in turn will alter the microbes the baby hosts. So this complex interlinked relationship exists and is influenced by our feeding practices. So I think the aims of early establishing feed are multiple. They involve minimizing threats to survival, and that's largely around reducing NEC and sepsis rates. They include optimizing growth, and we need to think about both the brain and the body growth. And ideally, they will optimize the microbiome and the metabolic functioning so that this preterm baby is optimally set up for a healthy later life. So when we think about when those outcomes are measurable, only some of them are measurable early. So threats to survival, NEC and sepsis and growth are, but the others are revealed only much later in the preterm baby's life course. So I think the outcomes that matter, and therefore what we should be aiming for, are no necrotizing enterocolitis, no late onset sepsis, and a healthy microbiomic and metabolic profile that lead to a healthy breastfed 1-year-old, and that should lead to healthy older age. And if we focus our efforts on breastfeeding, that we would also have positive societal impacts. So in an ideal world, we'd be able to optimize all of these outcomes, but it is likely that there will be some trade-off between optimal outcomes. So a summary key message slide, which is that the outcomes that relate to how we start and introduce enteral feeding are complex and potentially competing. Given the importance of this as a topic, you would imagine that neonatologists across the world would agree with how they do that, and therefore that time to full feeds would be pretty standardized. This study looks at that in 13 different NICUs on 5 different continents, with 5 of those in southern China. And what they actually demonstrated was a wide variation in time to establish full feeds at 120 mils per kilo, ranging from 8 days to 33 days. They also looked at those key outcome measures that we've just discussed and showed wide variation in mortality, change in Z-score from admission to discharge, and rates of NEC. But when they tried to link those outcomes to the time to establish full feeds, there was no clear relationship demonstrated between them. So the very beginning of our baby's journey is the introduction of enteral feed and the use of early colostrum. And for the most preterm, this is perhaps the most crucial window. So there is meta-analysis data of the use of buccal colostrum in preterm infants, looking at those key outcomes that we've discussed. And what that data show are that necrotizing enterocolitis rates, late onset sepsis rates, and mortality rates are not different in infants offered or not offered early buccal colostrum. But what early buccal colostrum does appear to do is improve immunological endpoints, and that's measurable in both urinary lactoferrin and urinary secretory IgA levels. And it's also been demonstrated that buccal colostrum leads to more maternal milk receipt over the preterm infant's early life course. So in the UK, the current British Association of Perinatal Medicine framework is that preterm mothers' infants should be expressing before 2 hours of age, and the baby should receive buccal colostrum within 6 hours. And that to achieve that, antenatal information should be provided where possible. And our own practice is to have colostrum kits everywhere and for everyone. And what this does is send an early message to mum that it's her milk that's important. And that early colostrum receipt also allows early bacterial seeding of the mother's bacteria with important impacts on baby's gut function. So that early first colostrum leads to more maternal milk receipt and will then lead to these additional benefits that we see early and later and very late in a preterm infant's life. So own mother's milk is the key to health, the food choice for all preterm infants. And we need to remember that maternal milk is much more than just the food constituents. It's a biologically active fluid, and it is the mechanism by which a conversation takes place between the mum and the baby. And that conversation is modulated through these products which are not present in formula feed and are often reduced in donor milk. So the next key message is that receipt of early buccal colostrum should be the aim for our preterm infants. The next question is whether we should aim to begin enterally feeding and increasing feeds early, or whether infants should deliberately spend a period simply receiving that buccal colostrum. And one of the key studies to help us in this is the ADEPT study, which enrolled infants with a gestation of less than 35 weeks and who were at the highest risk because of a combination of absent or reversed end diastolic flow and being born with a weight less than the 10th centile. So the interventions were to start to feed either on day 2 or day 6, and the outcome was the time taken to achieve full feeds defined as 150 mils per kilogram per day. And what you can see here are that those key clinical outcomes are not different in the two groups, but that the age at full feeds is different. So the infants who were fed early reach full feeds on day 18, as opposed to day 21 for the later fed infants. So there are 3 days less parenteral nutrition received by the early fed group. So that would suggest that the right thing to do is to offer to begin enteral feeding early. There is also meta-analysis data, which looks both at all infants and those specifically with absent or reversed end diastolic flow. And as you can see, there is no impact on neck rates by attempting to feed these babies earlier. So just some extra data to support the early use of maternal milk. So this is data from the Dutch group looking at the impact of how much of the baby's enteral feeding in the first 10 days of life was from maternal milk. And what you can see is that survival free of sepsis or neck is higher in infants who have the most maternal milk and lowest in infants who have none, with those receiving the intermediary with intermediate survival without neck and sepsis rates. So the next key message for us is that we should be aiming to start our feeds early. So our own starting approach is to view no baby as not being able to have buccal colostrum, that we wish to start sooner because that will lead to more maternal milk ever being received by the baby, but that in order to do that, we have to have mechanisms to have maternal milk available to us early in the neonate's life course. And our nursing standard is that our infants are fed unless they have specific instructions not to do so. We're also extremely careful not to waste those initial small volumes. So in the beginning, we give small boluses, we give it fresh, direct from the mother to the baby without freezing or refrigerating in between. We have strategies to try and improve our early maternal milk availability, which are around the unit culture and language, and everything that everyone thinks and says and does should encourage mums to be expressing their own breast milk. You need education and leadership to achieve this, and the assumption on the unit has to be that the tiniest preterm babies will receive their mother's own milk, and it is underpinned by this early receipt of colostrum. And some units actually go as far as prescribing mother's own milk for their preterm babies to demonstrate the importance of it. So the next key message is that we should be aiming to maximise maternal milk receipt early in the preterm infant. Our next challenge is to think about how quickly we should increase once that first milk has been introduced. so how fast or potentially how slow we should go. And you might imagine that these outcomes are competing, so NEC might occur more commonly in a faster fed baby, and sepsis might occur more commonly in a slower fed baby. The key trial to help us understand this better is the SIFT trial, which is a very large trial of 2,804 infants, and importantly, all endpoints, so every case of NEC and sepsis was reviewed by a blinded endpoint review committee. So the infants here are less than 32 weeks or less than 1,500 grams. The fast intervention arm were fed with an increasing rate at 30 mils a kilo a day, and the slower increasing rate was 18 mils per kilo per day. And the outcome was survival without moderate or severe impairment, alongside other clinical secondary outcomes, as we've discussed. So what you can see here is that neither the primary outcome nor the clinical secondary outcomes are different in the two groups, so that there is no significant difference there. But you can see that the infants who are fed faster achieve their full feed sooner, so on day 7 as opposed to day 10 for the slower fed infants. It's also important to recognise that infants were enrolled into this trial at a point when the physician was already ready to increase feeds, so not from birth, and the median age at which that happened was 4 days of age. One of the secondary outcomes was also motor impairment, and we did demonstrate a higher motor impairment rate in the infants who received faster feeding. We also undertook a health economic analysis alongside this and demonstrated that faster feeding was more expensive by £267 per baby. The meta-analysis data is shown here. It is dominated by the SIFT data, but you can see that for mortality, NEC, and sepsis, there is no difference in attempting to feed slowly or quickly. So the conclusions on increasing feeds are that the intention to feed faster achieves full feeds quicker, and therefore less PN is received, but this is only true once the clinician is happy to increase, and that in meta-analysis there is no difference in the key clinical outcomes. Therefore, that fast advancement may suit some babies, but the converse of that is that no harm has been shown by slower advancement either. So the key message here is that increasing in that range between 18 and 30 mils per kilo per day appears safe for the outcomes of NEC and sepsis. So I want to think a little bit about milk tolerance. So if you have that set approach of early colostrum, early introduction of milk, and a moderate pace of progression, are there specific babies or specific symptoms where you should slow down? Or are there other things such as stool markers or urine markers or potentially breath markers, or even the development of a smart nappy that would tell us that this specific baby needs us to take a different approach? Well, when we think about all of those things and the possible things that would guide us, we need to recognise that many of those terms are very poorly defined. So distension, the colour of an aspirate, or the description of a baby as constipated is very subjective. And for most of these, there is either no or very low quality data. There is some data to guide us on the use of routine gastric aspirates. So 2 trials with a total of 141 infants. And what you can see here is that there is no difference in necrotizing enterocolitis rates, but that the time to regain birth weight was longer in infants where routine gastric aspirates was undertaken. So it's possible then that there is little benefit from this routine practice, but it's potentially very hard to stop when it's undertaken in most nurseries. And there is potentially a UK trial coming to try and guide us further. But the key message in relation to tolerance and using aspirates to measure this is that it's very subjective and possibly harmful. So the last thing we're going to think about now is how we monitor gut health. And given that the thing that we're trying to achieve is a happy, successfully breastfed infant, we could simply look at the proportion of our babies who end up in that position, or we could look at the converse and look at babies who experience adverse effects that are gut related. When we remember that the outcomes of interest are multiple, it helps us to think about how we might monitor our own success. So there are some endpoints that we would suggest are monitored locally by audit, so rates of NEC, sepsis, mortality, 2-year neurodevelopmental outcomes and growth, although the definition of good growth is the subject of a whole separate talk. If units do this, they can then compare their own practice over time and with other units through things like the Vermont-Oxford network. But it's only really possible to do this for those early outcomes that we discussed earlier. We can then also potentially monitor the mechanisms by which gut health is mediated, but at present they're poorly understood. But it's possible that from the baby, We might develop and have soon available to us some bedside microbial or metabolic assays, either for stool or urine, and there are already laboratory assays that look at stool inflammation, which are potentially helpful. We need to also remember this key interaction with milk and the baby and the gut, and we should be looking at and recording our use of maternal milk and potentially thinking about the detail of that, so the HMO profile, the IgA profile and the bacteria in the maternal milk, because those things are actually potentially modifiable in real time, and you'll hear more about those as the day's conversations go by. We then need to not forget the intermediates that tell us how we're doing with an individual baby, so the monitoring of routine biochemistry, micronutrients, glucose protein levels and iron. And obviously growth is a key intermediate marker of gut health, but there are lots of issues around which standard of growth we should be aiming for. And likewise, microbiome monitoring and the use of pre and probiotics in your own unit and antibiotic use can all be monitored. So the last key message I have for you is that monitoring requires understanding of your own practice and outcomes and local audit. So a final word about parenteral nutrition. It's the unseen and largely non-discussed part of enteral trials when we discuss how we go about feeding our babies. There is data that suggests that acutely ill children may not benefit from early PN, but the nutrients deficits that a preterm baby experiences are already potentially large, even when we have early use of parenteral nutrition. And fluid management in our tiniest babies is extremely complex. It's also important to remember that preterm infants are not necessarily ill shortly after their birth when we're establishing enteral feeds. So to summarise, the key steps to take our baby from a 0 nil by mouth baby to a happy, successful breastfeeding baby are that the detail of our practice is what matters. Everything we do should be focused on babies receiving their mother's own milk as close to fresh as possible, including buccal colostrum before 6 hours of age, an early start to enteral feeding, with the progress driven by the baby and the knowledge that slower is not obviously harmful. We should take all steps to promote a healthy microbiome, including use of fresh maternal milk, thoughtful antibiotic use, and potentially the use of probiotics. And we should audit both our practice of these measures and the outcomes that we actually achieve. Gut health is unfortunately complex, hard to measure, and there is no single success measure and no single endpoint. It's important to measure locally your rates of survival, sepsis, NEC, and outcomes, but also to support trials that have these outcomes, whether they be pragmatic clinical trials or mechanistic trials. So I hope that that's been helpful. This is our research website where you can see more information. Thank you very much.
Our next speaker today is Professor Frank Bloomfield, who is Director of the Liggins Institute at the University of Auckland in New Zealand. Frank is also President of the Perinatal Society of Australia and New Zealand, is an editor for paediatric research, is a member of numerous important committees and working groups across the UK, and has also been a council member for the Perinatal Research Society in the US. His main interests are around neonatal growth and nutrition. He's principal investigator for 2 very important large randomized controlled trials involving neonatal nutrition, and particularly examining the role of protein intake in these babies. He's also been involved in looking at neonatal pulse oximetry and has a major interest in supporting basic science work, looking at maternal nutrition and pregnancy outcomes. And Frank is going to be talking about fetal and postnatal growth, but also aspects of SGA, IUGR, and catch-up growth in these babies. Thank you.
Thank you very much for the invitation to talk to you about strategies in neonatal care for growth and development. I don't have any disclosures relevant to this talk to make. What I'd like to talk about today is the link between nutrition, growth, and neurodevelopmental outcomes in very small preterm babies. And then just to provide you with some preliminary data from a recent randomized controlled trial we've been undertaking, which is aiming to understand how nutrition affects neurodevelopmental outcome. If we think about the nutrients needed for normal brain development, they are of course many, including the macronutrients such as protein, energy, and fat, but also many micronutrients and vitamins, shown here: zinc, thiamine, particularly iron and copper, and of course energy. So if we think about the association between nutrition and neurodevelopmental outcome, we often use growth as a proxy for how good our nutrition is, thinking that good growth will then lead to good neurodevelopmental outcome. And indeed, there are many observational studies in the neonatal literature showing that good growth is associated with good neurodevelopmental outcome. So nutrition could affect growth directly, measured as weight, which is how most neonatal units assess growth, as shown at the top here, and then good growth could lead to neurodevelopmental outcome. Or nutrition could really just be important for brain growth and development, and this is commonly measured by the proxy of head circumference. And then this could be what leads to good neurodevelopmental outcome. Or of course, nutrition could lead directly to neurodevelopmental outcome without growth being important at all. We do know that nutrition in these extremely preterm babies is quite challenging. This graph from one of Chris van den Ecker's papers a few years ago now shows the association between amino acid intake in very preterm babies and nitrogen balance, showing really that an amino acid intake of at least 1 gram per kilo per day is needed just to maintain a zero nitrogen balance. And once muscle turnover is taken into account, this rises to at least 1.5 grams per kilo per day. And therefore, if we want growth on top of that, we can see that we're going to need even more, 2.5 or more grams per kilo per day of amino acids. Of course, what actually happens when these extremely preterm babies are born is that there's a rapid drop-off in their protein intake. In utero, it's somewhere between 4 and 5 grams per kilo per day. At the upper end here, if you take into account the protein that babies can get from swallowed amniotic fluid. But when the cord is cut, of course, this drops precipitously. And even with very careful attention to nutrition intake, we're lucky if we manage to get 2 grams per kilo per day into babies on the first few days after birth. So what evidence is there that the level of nutritional intake, particularly protein intake, which is what I'm going to focus on today, is important for growth first of all, and then neurodevelopment, which is of course what we're really interested in? Well, there is a Cochrane review, of course. This is from 2018 by David Osborne and colleagues, which has a whole host of different measures in there, which you can see in the Cochrane review online. I've just selected a few here, and this one shows you the effect of a higher versus a lower parenteral amino acid intake on weight at discharge. Now I'm showing weight here rather than some of the other measures for weight that we could use, such as Z-score at discharge, Z-score at 36 weeks, Z-score change from birth or another time point until discharge. And the reason I've chosen weight is because this is obviously a very easy measure, and therefore it's available for most of the studies, whereas some of those other data are only available for a very small number of studies. We can see here that in total, there are about 800 babies in these randomized controlled trials, and there is a beneficial effect on weight of a higher amino acid intake, but it's not very substantial, perhaps about 80 grams. But weight, of course, can be anything. It can be fluid, it can be fat, or it can be lean mass. And therefore, it's difficult to interpret exactly what this means. So how about if we look at head circumference? Again, this is actual head circumference rather than Z-scores. And if we look at head circumference, we can see that in this meta-analysis, there is no effect of higher parenteral amino acid intake versus lower on head growth at discharge, head circumference at discharge. And of course, if we look at the really important outcome, which is neurodevelopmental outcome, there are only 2 trials with a total of 200 babies showing no effect of a higher amino acid intake on neurodevelopmental outcome. Now, there are some other studies that have also assessed neurodevelopmental outcome, but this wasn't the primary outcome of the trial. And many of them are follow-up cohorts, and they show basically, most of all, no association between the nutritional intake, the protein intake, and neurodevelopmental outcome. There are some that show an inverse relationship, particularly the very small trial of Blanco et al., but mostly there is no effect. Now, in the Cochrane review, almost all of the evidence cited is graded as being of low or very low quality. And this, of course, means that we really do not have the evidence at present to tell us whether a higher amino acid intake is beneficial for growth and neurodevelopmental outcome in extremely low birth weight babies. The other question that's become very topical recently is whether early versus late parenteral nutrition in neonates in intensive care is of benefit or of harm. Again, there is a Cochrane review, but it's quite old now, from 2013, and again has a very small number of babies, fewer than 150 in total. This Cochrane review does show that early parenteral nutrition leads to fewer days to regain birth weight, but an increased blood urea nitrogen for what that's worth, and also less hypoglycemia, but hardly very robust evidence. And of course, the Peppernick trial in pediatric intensive care, along with some trials in adult intensive care, have raised concern about providing early parenteral nutrition to people in intensive care. In the Peppernick study, there were 209 babies, and these were mostly term babies, and 145 of them were less than 1 week of age when enrolled in the trial. And this trial, of course, compared late versus early parenteral nutrition. And in these babies, the likelihood of earlier live discharge was greater in those who received their parenteral nutrition late. However, overall mortality was not different, neurodisability was not different at 2 or 4 years. Nevertheless, there were some sub-analyses, particularly externalizing behavior and internalizing behavior, that suggested that late parenteral nutrition may be of benefit. So this dearth of available evidence and the low quality of the evidence that is available has led us to undertake the PROVIDE trial here in New Zealand with a couple of Australian units. And here is the PICO statement for this trial, which is that in extremely preterm babies who have an umbilical artery catheter in situ, does an extra 1 gram per day of intravenous protein for the first 5 days after birth, compared with saline, improve survival free from neurodisability at 2 years of age. So the primary outcome is neurodisability, survival free from neurodisability. And the reason we're using an umbilical artery catheter is that's the route for the extra 1 gram per day of intravenous protein. And we've done this because most of the RCTs in preterm babies struggled to separate out the two groups when just using the intravenous route. And so the planned difference is often not matched by the actual difference. Here's the consort diagram for the PROVIDE trial. We assessed nearly 1,000 babies. 482 were excluded, 240 because they didn't meet the eligibility criteria, 88 declined, and 150 were missed, meaning that we randomized 500 babies. Now, we had deferred consent for up to 24 hours approval by the ethics committee. And following that deferred consent, 40 families declined to participate. We were unable to consent 10 within the required 24 hours, and 6 died before consent was obtained, 5 randomized in error, leaving a total number recruited of 434, and the planned sample size was 430. You can see that we finished recruiting in October 2018, and in fact, we have just assessed the last baby at 2 years corrected age this month. And so we're hoping that the primary outcome of survival free from neurodisability will be available later this year. In the meantime, we have undertaken some secondary cohort analyses, particularly interested in exploring the associations between the nutritional intakes and growth outcomes, and also to investigate how nutrition in preterm babies affects refeeding syndrome. And that's what I'm going to turn my attention to now. So the first thing I want to point out about this cohort is that baseline nutritional intakes were not mandated. And that's because there is no real agreement on what baseline nutritional intakes would be. And that means that the participants received a wide range of nutrient intakes due to the differences in nutrition policies. Babies were recruited from all 6 level 3 neonatal intensive care units in New Zealand and 2 in Australia, so making 8 sites in total. So we've undertaken a cohort analysis investigating the relationships between macronutrient intakes and growth. And we did this by recording all actual intakes for the first 4 weeks after birth. And you can see how we've recorded those, but this was very carefully done to make sure we had precise nutrition intakes. Now, of course, if we're going to assess this with growth, a key question is, well, what is normal growth in extremely preterm babies? And I think the answer to that is that we don't really know. Of course, for a long time, the recommendation has been that postnatal growth and body composition of preterm babies should be equivalent to that of normally growing, healthy human fetuses of the same gestational age, which would mean that as we monitored the Z-score change, for example, this would be 0 between birth and whatever point of time we are measuring. We now realize that that really is not an appropriate measure, and that after birth, all babies, and including preterm babies, will have postnatal weight loss due to the change in extracellular fluid component of body composition, and then also be regression to genetically determined growth. And most people now, I think, will accept that a Z-score change of up to -0.8 can reflect this normal postnatal adaptation. Given that there may be some regression to a mean, we can think that maybe acceptable growth would be somewhere between -0.8 and 0.8. And so for our analyses, that's what we've taken. And we've suggested that we shouldn't just be focusing on weight, because as I've mentioned, weight really is not growth. Weight is just mass, which can represent a whole host of things such as fluid and fat. And if we really want to assess growth, we also need to assess length and head circumference. Length, of course, being linear growth, which most pediatricians and endocrinologists would regard as being true growth, and head circumference, which is a proxy for brain growth. And so we suggested that target growth should be a Z-score change between -0.8 and 0.8 for all three of these parameters. So for the analyses we've undertaken here, we started with the 434 recruits to the PROVIDE trial, and then a number of babies died between birth and 36 weeks corrected age, as would be expected for these extremely preterm babies, leaving us with 363 babies at 36 weeks corrected age, or 84% of the initial cohort. These are small babies, median weight of 770 grams, median gestation of 25.7 weeks, 11% small for gestational age using the Fenton growth chart. But you can see if we're looking at the birth Z-scores that these are pretty close to 0. And of course, that's a reflection of the way that we assess growth at birth in preterm babies. And what we do is we plot their growth on population growth charts that are derived from babies born preterm. And therefore, it's not surprising, as shown on the left here, that when we plot babies of a large cohort such as this, they're distributed fairly symmetrically on that preterm population growth chart. But if we were to plot the same babies on an estimated fetal weight chart of fetuses who are remaining in utero of the same gestational age and who go on to deliver at term, we can see that there's really quite a marked shift to the left, as shown in this graph on the right here. And this really is indicating to us that as a population, preterm babies are growth restricted. And indeed, there are some fairly good studies indicating that growth of a fetus is linked to gestation length, even growth in the first couple of weeks of pregnancy. So what does the nutritional intake of these babies look like? This slide shows you the pattern of growth in the pattern of nutritional intake in the 8 different hospitals that took place in this trial. Across the bottom there, you have the measurements at 4 different weeks with the mean intakes across those weeks. And on the y-axis, we have the protein intake in grams per kilo per day. The blue shading shows you the intravenous protein intake, and the grey shading shows you the enteral intake. You can see that in these 8 hospitals in New Zealand and Australia, there is marked variation in the pattern. So if we look, for example, at sites 1 and 3, there is relatively low protein intake, below 3 grams per kilo per day, and this tails off quite slowly as enteral nutrition is slowly increased. And again, the final protein intake on full enteral nutrition or near full enteral nutrition is fairly low, below 3 grams per kilo per day. In contrast, if we look at sites 5 or site 7, we can see that the initial intravenous protein intake is substantially higher, 3 grams per kilo per day or above, averaged over week 1, and that this falls off fairly precipitously as enteral nutrition rises rapidly. So that by the end, we are achieving 4 grams per kilo per day of protein. How does this relate to the growth of these babies? Well, not surprisingly, growth varies quite substantially. And here we're showing the Z-score change now between birth and 36 weeks corrected age. And of course, as I alluded to earlier, if there was no change, babies would be sitting along here. And we can see that almost in all hospitals, there is substantial drop-off for all 3 parameters. However, for most hospitals, weight does fall within the expected growth rate of up to minus 0.8 standard deviations, but not for all hospitals, and particularly Hospital 1, which I pointed out as having a low protein intake, has very poor growth. If we look at length and head circumference, we can see that almost all babies have poor length growth, and quite a few of them, again, particularly Hospital 1, have a poor head circumference growth. So here indeed, nutritional intake is associated with growth, particularly head circumference growth. What about the effect on other parameters? I mentioned that we can think of preterm babies as being growth restricted, and that's largely due to them being malnourished in utero. In the developed world, most of that malnutrition is due to placental pathology. Globally, it's due to either maternal undernutrition or due to malaria. So if we're providing nutrition to malnourished people, there's well-described refeeding syndrome, whereas the sudden provision of nutrition leads to an increased phosphate use for energy production in the cells. This leads to depletion in blood phosphate concentrations, which stimulates parathyroid hormone, acts on the bone to release phosphate, and when phosphate is released from the bone, calcium also is released, and therefore calcium goes up in the blood and phosphate is low. So the classic appearance of refeeding syndrome is a low serum phosphate, potassium and magnesium, and a high serum calcium, glucose and sodium. And this has a variety of effects on health, as shown in this diagram. So what was the pattern of particularly phosphate and calcium, which are the 2 minerals that we measured in the PROVIDE trial? Well, we can see a significant drop-off in phosphate over the first week after birth and a significant rise in calcium. And we defined refeeding syndrome for the purpose of this study as a phosphate of below 1.4 millimoles per litre and a calcium of above 2.8. That occurred in 61% and 23% of babies respectively, with refeeding syndrome, the combination of both, occurring in 20%. Interestingly, there was a marked effect of small for gestational age, with 22% of babies with refeeding syndrome having SGA, whereas only 8% of babies without refeeding syndrome were small for gestational age. Refeeding syndrome was significantly associated with adverse outcome in these babies. For example, death before NICU discharge occurred in 11% of babies without refeeding syndrome, but in 32% of babies with refeeding syndrome. Grade 3 to 4 IVH was doubled in those with refeeding syndrome compared with those without, though that wasn't statistically significant. And you can see that there was no difference in NEC or grade 3 to 4 ROP. Sepsis also was increased by about 50%, relative increase of 50% with a p-value of 0.06. As I showed you for growth, there is marked variation by hospitals. So here we can see that the incidence of refeeding syndrome in the 6 New Zealand hospitals varies from 7% to 44%. The proportion of babies who died before discharge varies from 7% to 27%. And the proportion of babies who died before discharge who also had refeeding syndrome varies from 0% to 77%, showing that the nutrition that we're providing has marked effects on these babies. So just to conclude, in extremely low birth weight babies, nutrition and growth are highly variable, even within a small country like New Zealand with relatively consistent approaches. And we still need good, high quality evidence on the optimal nutritional strategies to support neurodevelopment. And we also really need to know whether growth in NICU is a proxy for neurodevelopmental outcome or not. Preterm babies of the population are growth restricted and they are increased risk of refeeding syndrome. And we really need to be aware of this so that we can address it when it occurs. I'd just like to thank the PROVIDE study group, particularly Dr. Barbara Cormack, who undertook her PhD on this with me and has been a long-term collaborator of mine, and also the whole PROVIDE team. And I'd like to thank you very much for your attention and look forward to any questions. Thank you.